Good evening and welcome back to Doctors in the House. My name is Dr. Darryl Hill, and as always, it's a pleasure to be here with you in the house. And today, we're fortunate to have our co-host and special guest today, Dr. Jameson.
Yes, hi. My name is Dr. Ian Jameson. I'm a cardiologist in the DC metro area, and I'm excited to be here with Darryl, my good friend and colleague, to co-host this show.
Yes,
Thank you.
Yes, sir. Today we're going to be talking about heart disease, and as many of you should know, heart disease is a leading cause of death, and I think we're very fortunate to have Dr. Jameson here with us today to just talk a little bit more about what this means and what are some of the things we can do to stay healthy. So I'm going to give Dr. Jameson a chance to just introduce himself again and give his address and contact information, and then we'll get into the show.
Okay, yes. So like Dr. Hill says, my name is Dr. Jameson. I'm a board-certified cardiologist with offices in a main office in Beltsville, Maryland. My office address is 10756 Rhode Island Avenue, Beltsville, Maryland. I also have offices in Bowie and in Columbia. All these addresses can be found on my website, which is www.metrocardiovascular.com. Again, that's www.metrocardiovascular.com.
And as always, I'm with Laurel Medical Associates, and my office number 301-497-0401, and I can be found on the web at laurelmedicine.com. So why don't we do this? We have a nice video that briefly describes heart disease. So I'm thinking let's go ahead and go to the video and then get back into the show. So enjoy this video real quick.
The heart keeps us alive, so having heart disease can be a very important factor in how long we live.
Heart disease is a big term referring to any disease of the heart.
Now, the most common cause is coronary artery disease.
And that refers to a buildup of plaque in the arteries. Over time, it can lead to narrowing of arteries and risk of a heart attack.
A heart attack is when a part of the heart muscle dies because it is deprived of blood flow or oxygen. Or it can be due to the heart having to work really, really hard that outstrips the oxygen supply.
Most coronary artery disease is preventable, says Dr. Hayes.
If you're smoking, stop. If you're a couch potato, get off and start taking 10 or 20-minute walks every day. Physical activity is medicine.
Know your cholesterol and blood pressure numbers and maintain a normal weight. These are all ways to help reduce your risk of heart disease. For the Mayo Clinic News Network, I'm Vivian Williams.
Well, there we have it. Heart disease, as you can see, is all around us, and there are things we can do. So, Dr. Jameson, why don't you tell us what your thoughts are about heart disease, and what are some of the things we can be doing?
Alrighty. So like the intro video said, heart disease is a combination of multiple diseases, the most common of which is coronary artery disease, which is a buildup of plaque and blockage of any of the main arteries supplying heart and blood to the heart. It's a really common disease, very pervasive in the African American community especially. Actually, I had an opportunity to talk to a group of women recently. You know, it was Pink Goes Red, and you know, we always hear about breast cancer, and there's a lot of push for prevention with breast cancer, but believe it or not, heart disease kills many more patients, many more women than breast cancer. Actually, 1 in 8 women in America would have some form of heart disease in their lifetime, as opposed to 1 in 25 with breast cancer. So it's a very important disease, and I don't think we are doing enough, especially in our communities where not only are we have a higher incidence of heart disease in both women and men, and we have increased morbidity and mortality, i.e. we die more and get sicker from heart disease compared to our Caucasian compatriots. So it's a very important thing, and the good thing about it is most of it is preventable, and it's all about lifestyle and, you know, listening to your doctor and doing the right things, and, you know, you can prevent or at least, you know, push back the initial incidence of heart disease.
And, you know, it's interesting too, because not just in this country is it the leading cause of death, but when you travel to the UK in Europe. Same thing over there.
Yes, not only in the UK and Europe, definitely in the Western world, but what we are realizing as well is that even in the developing world, it's overtaking the communicable diseases and becoming the most common cause of death.
Right.
It's followed by cancer, but definitely heart disease is the most common. And like we've said before, heart disease is an amalgam of diseases. There's coronary artery disease, there's congestive heart failure, and even hypertension and high cholesterol can actually be considered heart disease as well. And of course, we have abnormal heart rhythms as well. But I think today we'll concentrate primarily on coronary artery disease, since it's the biggest of the lot. And it's still the #1 cause of death in America.
Right.
Higher than cancer, higher than HIV, higher than road traffic accidents. It's still the #1 cause of death.
And you make a good point, too, because with cardiology and cardiovascular disease, there's so many things to talk about. But you're right. Today we're going to try to concentrate on cardiovascular disease. And as we talk about it, let's get right into it. Let's talk about some of the risk factors.
Okay.
And as I recall, there are some that are preventable and some which aren't preventable.
Yes.
So let's just talk about that.
Yes, so we always talk about nurture and nature, but even the ones that are not preventable can be modifiable. So the big risk factors for coronary artery disease are the presence of hypertension, the presence of diabetes, high cholesterol, obesity, especially, in men, a waist circumference of greater than 40 inches, and in women 38 inches. And the other diseases like kidney disease that are also contributory, and smoking, a big one, and living a sedentary lifestyle. So as you can see, a lot of this you can do stuff about. The first thing you can do stuff about is stop smoking. Some things you might be born with, and there's very little you can do about it, but you can stop smoking. And then we talk about not living a sedentary lifestyle. The recommendation from the American Heart Association is walking 30 minutes a day of brisk walking, or moderate exertion 30 minutes a day, 5 days a week, and for the other 2 days doing some strength training. So it's not a lot, and by brisk walking I'm not talking about just walking casually with friends, but actually working up a sweat, getting your heart rate up, and doing some brisk walking. You can do walking, you can do cycling, you can swim, all of which are good ways of getting your aerobic exercise. And then some strength training 2 days a week. We are talking about moderate strength training. You don't have to do anything excessive. 30 minutes I don't think is too much, but obviously in this day and age, everybody's so busy sometimes.
Yeah.
It's more than people can get in. So there's also talk about doing 15 minutes of vigorous exercise, like the highly trained folks like you, Darryl, can do very vigorous exercise, or spinning or something like that for 15 minutes, 5 days a week. So really you need to get some exercise in every day of the week, okay? And of course the next thing we can talk about is diet. Again, we'll start with the things that we can modify. There are so many fads out there, a low-carb diet, a low-fat diet. I think the important thing is to have a sensible diet of, low in carbs, especially your refined carbs, which is refined rice, sugars, potatoes, refined pastas, and increase your fruit and vegetables. So as much fruit and vegetable as you can, healthy portions of that. We talk about a card, your pack of cards. If you think about a box or a pack of cards, that size of protein.
Right.
And with the protein, it's preferably a plant-based protein. Or if you have to eat animal protein, we recommend more fish and white meat. And by white meat, we mean, chicken without the skin, broiled or grilled, not fried. And, actually turkey, so all poultry. And surprisingly, pork, but we're talking about the lean pork. I always tell this story about a patient who came with his wife to see me, and I was having this talk with him, and I told him about having lean pork, and 10 minutes after they left the office, I get a frantic call from his wife. Did you tell my husband he can eat ham? That's not what we're talking about. We're talking about lean pork that is grilled, not processed meat. Processed meat should be totally out of it, because not only is it jam-packed with salt, it's processed and it's not healthy, and it also contributes to the other the other risk factors, especially hypertension.
You know, it's interesting because I feel like as a society, we're getting smarter about nutrition. We're starting to learn how to read labels, and this whole movement towards a plant-based diet, a whole food diet is starting to pick up steam for many of us. However, it's hard to realize just what habits do to you. Some of us eat the way we've eaten for so long, and it's hard to make that change. So what I agree with you, there's got to be a movement in this direction.
You know, the truth of the matter is, you know, our forefathers were hunters and gatherers. So they walked to get their food. And even as recently as the beginning of the last century, we still bought our food at the farm gate, right? So you got your fresh meat, you got your fresh grains, rather than everything processed. Unfortunately, as you know, because there's so much convenience in walking to the supermarket now for foods, you know, we have to contend with the issues, especially with all the processing of meats and other foods and refining of foods. For example, all our grains, you know, it's all modern technology that has led to polished rice and refined pastas and all of that. Back in the day, I'm sure rice, I mean, there's wild rice now, which is not refined.
And brown rice.
And brown rice. So all of these have a higher content of fiber.
And I will
which
say,
helps, yes.
I will say we're planning to have a nutritionist come in and talk more about this, but we haven't even gotten into the whole fast food industry and how I call it the marketing companies know more about how we eat, what we eat than many of us do. So I guess we can say it's very important that we all think a little harder and prepare more so, because it's when you're trying to do things fast and you're eating those high-calorie, low-nutrient meals that really get us in trouble.
Yes.
But as we move forward with risk factors, anything else you want to comment on?
Yes. So obviously, those are the three things you can modify: smoking, your diet, and exercise. And the other risk factors, like a family history. So if you have a family history, if you have a first-degree relative, which means siblings, parents, or grandparents, first-degree male relative who has had a heart attack or has heart disease at an age less than 45, and in females 55, that is a risk factor. The other risk factors are diabetes, like we talked about, and high blood pressure. So you need to know you need to go for your physicals and find out what your sugar is, which is routinely taking with your blood work. You also need to know what your cholesterol levels are. There's a good cholesterol and a bad cholesterol. I'm sure we'll get into that further. You need to know what that is and what your blood pressure is. And obviously, we talked about obesity. Funnily enough, obesity is only now being figured out to determine whether it's a direct risk factor. But we know the waist circumference is, because what happens when your waist circumference is higher is that you develop something we call insulin resistance, and that leads to heart disease. Basically, your body, you get resistant to the insulin your body releases, and it increases your chances of developing heart disease.
So why don't you share with the audience, what are those classical symptoms which might suggest a heart attack?
Okay, so classically, and I'm glad you said classic, because we are realizing more and more, especially in women, that you know these symptoms are definitely not classic most of the time. But when the classic symptom for a heart attack is crushing mid-sternal, that crushing pain right in the middle, that does or does not radiate into your arm or up into your neck, which is usually associated with shortness of breath, dizziness, sweats, or nausea, or feeling your heart beating fast. So that's classic, usually sudden onset. And in addition to this, a lot of patients describe a feeling of doom, as if it's over for us. So if you have any of those symptoms, the suggestion is you call 911 immediately. Now, these are the symptoms for an acute heart attack, but don't forget, this could be insidious. It could creep on slowly. And so what we also talk about is angina, which is not an acute heart attack, but which suggests that you have a narrowing. And in this case, patients classically present with chest pain that comes on with exertion or with stressful situations and is relieved with rest. That's the classic.
Right.
But as Darryl will tell you, and we actually had a common patient recently who didn't have those symptoms. A patient could come in with shortness of breath, or just feeling generally fatigued, or getting sweaty for no reason, or nausea, especially female patients, and especially female patients with diabetes. In fact, we know that females are less recognized when they come to the emergency room with heart attacks, because one, there's always been an assumption that they have less heart attacks than males, and secondly, they have these atypical presentations. Another thing I forgot to mention was that females, as far as risk factors are concerned, generally before menopause, women are sort of protected from heart attacks, but once they pass menopause, their risk approximates the risks in men, which is not to say, I'm sure we've all seen women, premenopausal women who have come in with heart attacks, so especially those with the genetic predisposition.
So let's comment real quickly too. There are some groups of people and patients that have different issues when it comes to heart disease. Like, for example, diabetic patient.
Yes.
What would you say is more characteristic about a diabetic patient and heart disease?
Well, we generally assume that anybody who's had long-standing diabetes, and the definition of long-standing really differs, but to my mind, anybody who's had diabetes for more than 3 years, and I talk about type 2 diabetes, which is the kind that occurs in adults. Anybody who's had long-standing diabetes is assumed to have coronary artery disease until proven otherwise. So any diabetic really should be following up and having at least an EKG annually with their primary care physicians. And if there's anything that shows up on that EKG, then it should be followed by consultation with a cardiologist. The other problem about diabetics, especially those who have got very long-standing diabetes, they could have what we call silent heart attacks. Unfortunately, the diabetes affects the nerves, and so they don't perceive pain like other people. So they can have a heart attack and it won't show up, which is why it's important that they have EKGs. So it's important that diabetics are screened for heart disease and are followed. And so we really are even more aggressive in treating diabetics. And I consider diabetes, as I'm sure you all know, is a disease where you have elevation in the blood sugar. But I would say that diabetes is actually a cardiovascular disease with associated high blood sugar, because that is what kills diabetics. It's not the high sugar, generally speaking.
And it's interesting too, because with our demographic changes, aging population, and the increase in prediabetes and diabetes, and the corresponding increase in cardiovascular disease, I can only imagine what that means for our audience and what it means for doctors and our cardiologists too. And so I guess we can get into it later, but if you want to comment briefly now, how does that affect some of the treatment at that population?
Well, I guess, like you say, I think the threshold and our degree of suspicion should be higher, and we should go aggressively looking for coronary artery disease. We also need to be more aggressive in treating their blood pressure, making sure their blood pressure is at goal. They should all be on an aspirin, and we should really be aggressively trying to get their cholesterol levels under control. So for me, any diabetic should have the same goals in cholesterol level reduction as somebody with established coronary artery disease. So the bad cholesterol, which we call the LDL, we generally like it to be less than, 100 is good, 70 is great, but for diabetics, I always want it below 70.
Now, my understanding too, and I want to hear your opinion, even if the cholesterol is normal, are you still giving that cholesterol medication?
Yes, because especially, it's what do we define as normal? That's the thing, you know. So usually, if you look at the standards, even a bad cholesterol of 130 used to be called good. But in these patients, we need to treat it, because the thing about, and this is only, at least for now, a specific group of cholesterol medications called the statins. And the statins, in addition to lowering the cholesterol, actually stabilize the plaque. You know, if you remember the cartoon we saw at the beginning, there's a plaque buildup in these arteries, and it's when these plaques become unstable that you have a rapidly developing clot that it leads to heart attacks. So we know the statins, especially the more potent ones, stabilize that plaque and definitely lead to a decrease in heart attacks.
And the reason why I raise that question is because you get a few patients in the office who are diabetics and their cholesterol's perfect, especially before that diagnosis of diabetes. And then you say, here's another pill, and there's always some confusion.
There's a lot of pushback, and hopefully we would have a panel discussion one day on the benefits of treating lipids, because there's a lot of negative press out there as far as the statins are concerned, a lot of which is undeserved. I'm sure we both remember the incidence of heart attacks when we were medical students and when we were residents. It's definitely reduced, and I think one of the reasons is because we are giving many more patients statins. So in the right patient, and the whole thing is selecting the right patient, statins are still a very valuable treatment, and part of the treatment to prevent heart attacks.
And what we'll try to do is when we get into the second part of the show, we'll focus a little bit more on diagnostic procedures and the treatments too, so we can just highlight those points. Let's move on to, what about sleep apnea? Any particular cardiac issues?
Yes, so first of all, maybe, even though that's more in the realm of the pulmonologist and the sleep specialist, it's something we come across all the time. And sleep apnea is a situation in which patients, for a variety of reasons, don't actually have a good enough sleep because through the night, on multiple occasions, they actually stop breathing. And when that happens, their heart and their lungs are starved of oxygen, and that has long-term sequelae. The usual problems, we usually see these with patients with very big necks, what we call nuchal obesity, patients who are overweight, and patients who have problems with the anatomy of their mouth, their oral cavity.
And any particular cardiac manifestations?
Yes. The biggest thing we are concerned about with patients with sleep apnea is their blood pressure is generally very difficult to control.
I've seen some of my highest blood pressures with sleep apnea. I'm talking 200s, 120s, easy.
And really, once they treat their sleep apnea, their blood, they actually are able to get off some of the medications. Obviously, the biggest thing to do is lose weight, avoid alcohol. And that is the beginning, but some of them need to be on what we call CPAP, which is a machine they have to sleep on at night to keep their airways open and prevent the drop in oxygen levels. And so that's the biggest thing. The other thing sleep apnea can cause is it can cause the pressures, because their oxygen levels are down, the pressures in their lungs go up. And they develop a condition called pulmonary hypertension, which is basically high blood pressure in the lungs. And that leads to the failure of the right side of the heart and can eventually affect the left side,
Wow.
Yes.
So why don't we just take a quick moment? Why don't you tell our audience what made you become a cardiologist? Where'd you go to school? And how are you enjoying the world of cardiology?
Okay, I'm originally from Ghana, and I did my medical school back in Ghana. I came to the States and was in Mount Sinai Beth Israel Medical Center in New York, where I did both my internal medicine and cardiology fellowship, after which I moved to this area, and I've been here since then. I've got interest in coronary artery disease, nuclear cardiology, echocardiograms, and vascular medicine, as well as congestive heart failure. Actually, as you know, Darryl, I do a lot of clinical trials in these areas as well. Yes, and I've been a principal investigator in quite a few trials in these areas.
What's been your biggest thing that made you feel good about a patient or being a cardiologist?
Well, I think of all the internal medicine subspecialties, at least as of now, and I know some of my colleagues in other subspecialties would probably not agree with me, but I think, one, I came in a time when there was a lot of progress being made in therapeutics in cardiology, and I feel like we have the greatest impact. We are actually able to cure patients, or modify their lives extensively, as opposed to other forms or other subspecialties in the internal medicine space. So I found it very satisfying. Obviously, the fact that cardiology or cardiac disease was the number one cause of mortality made it even more satisfying professionally for me. And we've seen, even though we've not made as much serum as soon as possible, and we are doing things differently. Now at least in most major metro areas, we are able to get a clogged artery open within 90 minutes and save heart muscle. And we're doing that more efficiently now because patients are going straight to the cath lab and having a cardiac catheterization and a stent placed. When I started, and this ages me, when I started residency, we were doing this using a clot buster. Now it was not as good, so we infused a clot buster. It took care of some of it, but obviously now we are doing much better with more modern technology. So
we have more research, more treatment.
It says more treatment,
and
but
higher standard.
Yes, but apart from that. And that's why I said statins and such a bad name. We in the field are doing more in preventing, in early diagnosis of coronary artery disease, and in putting patients on the right medications. The statin, making sure their blood pressure is controlled. And one medication that has been so valuable has been an ordinary aspirin. We've really gotten more aggressive, and part of that aggressiveness means people are taking more medication too. So as long as that person can come to terms with taking more medication, they tend to have a better outcome. But I think there's still ways to go. Like I was saying, especially in women, most women are acutely aware of the need to have their mammograms, need to be screened for breast cancer. And, like I said in a recent talk, a lot of women, they didn't realize that heart disease actually kills more than breast cancer. And I asked, so how many of you have ever thought of getting a screening for heart disease? And, not a single hand went up. Now, so there's still some work to be done, especially in our communities.
So we're going to be preparing for our first break. I'm curious, as we prepare for break, anything that you're seeing different in the majority population compared to African Americans when it comes to heart disease? Anything stand out to you?
Well, like I said before, our mortalities and morbidities are higher, and I think there are a variety of reasons. One is that is access. There's a big problem with access, that kind of improved after the Affordable Care Act, but we are falling off again.
Right.
So because we not only is access a problem, we are less likely to have good insurance. Excuse me.
And it's hard to believe that insurance can really dictate these types of treatments and interventions, because my understanding, my utopic understanding, is if someone shows up at the ER or the hospital, they're going to get the treatment they need, and all the financial stuff get worked out later. How does that play out for you?
Well, which is generally true. So if somebody comes with an acute, what we call an ST elevation MI, they will get the treatment. But don't forget, the reason we are trying to prevent them from getting there in the first place. So it's important that they get to see a primary care physician. Get important. To do the screening. And we know that even despite the fact that you say, insurance should not play a part when you get to the ER, we know that I mean, it's very clear. Uninsured patients die at a higher rate from acute diseases than insured patients, you know. And I wouldn't want to say physicians, you know, especially in an acute situation, look at it. But it's not only getting the acute treatment in the hospital, it's the follow-up, being on the medications to prevent a secondary event. Right. And to prevent that stent from closing up again. So, you know, and I've seen it where patients have had their stent placed and they can't afford the medications.
Well, you make a very good point, because as you talk about that, I'm reminded of many situations with the prior authorizations and insurance denials. And you're right, that long-term plan, once you do your intervention to prevent problems, can be a big challenge. So for those people who like to call in with questions, the phone number is 240-719-2560. Once again, 240-719-2560. So I think we're going to take our first break, and we will see you on the other side, where we'll talk more about treatments, diagnostic procedures, and anything else that can help you. Thank you.
In 2018, I personally helped several people reclaim their healthy lives with a ketogenic lifestyle. Together with our team at Wakaya Perfection, we have helped over 4,000 people struggling with weight loss, burn off unwanted fat naturally, control hypertension, type 2 diabetes, and high cholesterol with our Beulah Fit Keto Fuel Shake and high-impact ginger and turmeric. Contact me for yours. Buttons about that ketolife.mywakaya.com. That's BUTTONSBOUTTHATMYWAKAYA.com or call 202-875-3926.
So welcome back to Doctors in the House. We are in the house talking about cardiology and heart disease today, and we are fortunate to be hearing from Dr. Jameson. So we're going to get into talking a little bit more about treatment and diagnostic procedures. So let's get right into it. Let's talk about those studies and tests that help us figure things out with heart disease.
Okay, so obviously the first thing is to get a good history and physical. So you, in your history...
I think we have a caller calling in. Let's go ahead and take the call. Sorry to interrupt you there.
That's okay.
Hello, caller. Turn your computer down. And is there a question? Feel free to call back, caller. Thank you. Let's get back into the program here.
Yes. So the first thing is to get a good history and physical. Ask for the symptoms we talked about. Find out about risk factors, and obviously get your blood pressure. Make sure your blood pressure is well controlled. And the first thing you do at the bedside is get an EKG, and the EKG might be totally normal because you could have heart disease and have a completely normal EKG if you've not had a heart attack or if you're not having active symptoms. And based on the symptoms, one of the first tests we do is what we call the stress test, okay? And the stress test is a test we do to determine if a patient is at risk for a heart attack now in the future.
And the basic goal of a stress test is to do what?
It's really a diagnostic and risk stratification test. So it determines, it helps us diagnose coronary artery disease to about a 80 to 90% degree of accuracy. And also, depending on how long a patient walks on the treadmill, it gives us some prognosis as well.
So we're trying to get the heart working a little harder.
Yes. So basically what we're doing with the stress test is we are getting the patient's heart to work harder. As the heart works harder, there's an increased demand for blood. And if there's a blockage anywhere, the heart can't compensate for that increased demand. And it shows up on an EKG as changes. And sometimes we do imaging in addition to the EKG to increase the diagnostic yield. And there are a couple of different tests we do. We can do what we call a stress echocardiogram, or we can do a stress nuclear study, both of which show us what the heart is doing at rest and how the blood supply is after exercise.
I know it's interesting too because patients, when we're doing these tests, can have a regular stress test or they can have a pharmacologic stress test. Giving the audience a chance to understand what that means.
Okay, so do we have a call coming in?
All right, we'll go ahead and take the call. Caller, thanks for calling. Who's calling?
Hello.
How are you?
Thank you for having me.
How are you?
Fine, thank you, sir.
Thanks for calling. Well, what's your question, caller?
Well, I wanted to know, are there ways that you can tell if someone is experiencing a heart attack or having issues? Are there signs and symptoms to be able to detect?
I think that's a great question, caller.
Yes.
Thank you for your question.
Thank you. Okay, so like we said before, chest pain is the biggest thing. So you've got crushing chest pain in the middle of your chest, usually radiating down your arm or up your neck. That is suggestive of a heart attack, especially if in addition to that, you break out into a sweat, you get short of breath, you get lightheaded, or you feel your heart pounding, or you have this feeling of impending doom, like we call it. So that's classic. But then, sometimes it can present with a sudden onset of shortness of breath or unexplained sweats, or the chest pain can be different. We've had patients who've presented with, heartburn type chest pain, but anything out of the ordinary should immediately, lead to, some intervention or calling 911. I believe it's better to err on the side of caution. So if you have chest pain that is it's out of the ordinary, it's best to just call 911 and go to the ER rather than, do nothing about it. Okay. Sometimes there are symptoms leading to this, like you'd realize that days or months before your exercise capacity has gone down, or now you're getting chest pain when you walk when you never used to do that. So there are things that lead to that, but then definitely the hallmark is chest pain. So any form of chest pain that's out of the ordinary really should lead you to seek medical attention.
Any other questions, caller? Oh, thank you. It's interesting we talk about this because I think what we're hearing here too, if you have chest pain, you want to get it addressed, number one. Number two, all chest pain is not necessarily going to be a cardiac issue, but you don't want to take chances. Now, I'll be honest with you. I get confused sometimes because if you get that person who isn't exercising anymore and now they're walking around or getting back to exercising, they're going to maybe get some shortness of breath and maybe even some chest pain too.
Yes, some chest tightness.
What do you recommend on that one?
Well, again, it goes back to what we call, risk stratification. So somebody who's got the risk factors, somebody, a gentleman who is over the age of 55, a lady who is, or actually a gentleman over the age of 45, a lady over the age of 55 who has any other risk factor, you have to assume it's cardiac until proven otherwise. And it's very important because, a lot of times with patients, you really have to probe because, they've not exercised and they start getting short of breath and they assume, they'll tell you, well, I'm overweight, that's why I'm short of breath. And yet, you probe a little deeper and you do some testing and you find out that they do have coronary artery disease. And it's not just because they are overweight. So it's not, you should really not minimize these symptoms if you have them and try and self-diagnose. And definitely don't assume they are nothing. There's no harm in at least going to see your primary care physician. You don't even have to see a cardiologist, but at least your primary care physician.
And I think you make a good point, and that's why I'm making sure we talk about this, because more and more we're seeing heart disease at an earlier age, and younger people are having multiple risk factors too. And most people are going to be overweight and obese too. So and I'll be honest, it could be scary. It can be scary. And I'm sending more and more people to the cardiologist because even myself, the way you get more information is by doing that stress test, even in your low risk people to a degree. So, but getting back to the diagnostic procedures. Let's talk about that cardiac cath and what that means.
Well, before that, I'd like to, there are other tests you can do. Obviously, you want to know what their cholesterol is because if they've got a very high cholesterol, then that's a problem. There's another test that has been shown to predict heart disease called the highly sensitive C-reactive protein, which, in those arteries, there's inflammation going on in the plaque. And there's an assay that's very sensitive, and if it's elevated, it suggests a future risk of heart disease. So again, whilst you're trying to tease this out before you do anything invasive, these are tests you can use to help you figure out what's going on.
Are they covering that test, insurance?
Yes, they'll cover the C-reactive protein now.
And I guess we're pretty much getting more aggressive in that individual?
Yes. So somebody who has an elevated C-reactive protein should be on, remember you talked about the statin even with a normal LDL? Same thing, somebody with an elevated C-reactive protein should be on one of the high-intensity statins because it's been shown to decrease future events.
So let's comment, for that person who has established heart disease, what are the typical medicines might that person be on?
Okay, so the medicines are, now you're talking about secondary prevention. You're trying to prevent a future heart attack. So if they have had a stent, they should be on what we call dual antiplatelet therapy for at least a year post-stent. And that is aspirin, low-dose aspirin with clopidogrel, which is Plavix. Or, and I think, the move is more to one of the newer medications called Brilinta, which has been shown to be superior in most cases to clopidogrel. But at least they should be on aspirin and clopidogrel for a year, after which they can only continue on aspirin. They should also be on a beta blocker, like the most common ones are carvedilol or Coreg, and metoprolol or toprol.
Can you share why that's important? Why is that important, that beta blocker?
The beta blocker is important because, one, it controls the blood pressure. Two, it's been shown to prevent future heart attacks and also to prevent deaths or significant hospitalizations in the future from heart attacks. So it's important that they are on the beta blocker.
That's a long-established part of treatment.
Yes, absolutely. That's been around for years. Predates
anything else they should be taking?
They should be on a statin. And at that time, you want to drive their bad cholesterol below 70. Once they've had previous heart attacks.
Now, are you going right to the 70, or are you just giving that a certain dose of atorvastatin or something?
Well, usually once they've had a heart attack, they really should be on high dose. So they should be on at least 40 of atorvastatin or 20 of rosuvastatin.
Right.
Okay, we have another caller.
Yeah, this is important information, audience. We do have a caller. Let's go ahead and take the call. Hi, caller. How are you?
Hi.
Thanks for calling. Do you have a question for us?
Yeah, I wanted to find out what the difference between heart attack and heart failure is. And also, I wanted to know if there are any supplements that we can take to actually prevent heart disease, I guess, or heart failure. I don't even know the difference anymore. But if there are any supplements that we can take to prevent heart disease.
Okay.
Well, thank you for the call and the question. And that second part of the question was something I was going to be bringing up soon, too. But thank you.
Okay.
Dr. James, so go ahead and see if you can take
All right. So there are two different things. A heart attack is a condition where there's a decrease in blood supply to one or multiple walls of the heart, leading to damage to the heart and what we call necrosis of the heart muscle. Okay, that's a heart attack. Heart failure, on the other hand, is the heart's inability to keep up with the demands of the body. Okay, so in heart failure, the heart is not able to push out enough blood to keep up with the demands of the body. So there are two different things. Heart attacks can lead to heart failure. There are other causes of heart failure. But I know in lay language these two are used interchangeably, which is wrong. So a heart attack, which is what we call a myocardial infarction, is when there is an interruption in the blood supply to the heart muscle, whereas congestive heart failure is when the heart is either beating weakly or stiff so that it's not able to keep up with what we call the metabolic demands of the body.
Right.
Okay.
Okay.
Alrighty.
Thank you, caller.
Okay.
Thank you.
Now, the other question.
Which one?
Supplements.
Supplements, yeah. Yeah, that's a good question. I'm really wondering.
Yeah.
I mean, I know the studies have been out there about the omega-3s, and based on my understanding of the omega-3s, the data doesn't support it, but we're still doing it.
Yes. Yeah, I mean, again, I think that's why we both laughed when we talked about supplements, because I think more important than any particular supplement, and you're going to get all these things about supplements, is a heart-healthy diet, okay? Yeah. And a heart-healthy diet is enough to prevent a heart attack without actually adding any supplements. We talk about fish oils, and I think there's still a place for it, even though, the data has not borne out. I don't think there's any harm in adding a fish oil to your diet. Right. There's some very, very weak data on vitamin D as well, but is not really recommended. The other thing, of course, is a supplement called red yeast rice, which is actually, it contains a naturally occurring statin. Okay. So it would decrease your levels of bad cholesterol. Apart from that, I think the best supplement is walking and eating healthy. Right. I think we, as a people, we waste a little too much money on supplements that have not clearly been proven to impact outcome.
Now, what's your understanding, and give me your thoughts on the power of a statin? And do you see, with our aging population, most of us needing to be on that to help prevent the most common cause of death?
Yes, I think statins, again, used in the right patient population, is a very powerful medication. It actually causes a significant decrease in the incidence of heart attacks. There's actually a app that is available now, because I think there was a time you remember in the 90s, there was talk about putting statin in the water because it's such a good drug. Right. So there was probably indiscriminate use of statins, but now there's an app, especially for. It's clear that if you've had a heart attack, then there's no. Or if you're long-standing diabetic, or if you've got what we call established atherosclerotic disease, which is heart disease or other plaque formation in other vessels. But the question is, in patients who don't have established plaque formation, primary prevention, who should we use statins on? And there's actually an app now put out by the AHA, the American Heart Association, and the American College of Cardiology, which you can pull up and which we should all be using now.
Is that the one?
Yeah, ASCVD.
Is that the one linked to NIH, the calculation?
Yes, it's a calculation linked to NIH. Okay. So basically, you can just, you punch in the numbers, sex, race, blood pressure, diabetes, smoking. I don't think it is comprehensive enough. It doesn't include things like family history and other emerging risk factors. But it's enough to give you an idea. And I like it because you can show the patient exactly what will happen with statin use, where their risk over 10 years goes from 50% to 5%. That's very powerful data, and this is so it's not kind of arbitrary anymore.
And not just a 10-year period,
and lifetime,
but lifetime.
Exactly,
you're right, and it's a powerful.
It's very powerful.
Tool to use.
It's a really powerful tool, and So what I'll encourage listeners to and viewers to do is, it's something you can discuss with your physician. Once they get your cholesterol, ask them what your risk is and what any intervention will do for your risk.
It's interesting. This calculation is so important. I keep it on my webpage.
Yes.
laurelmedicine.com. So feel free to go there and plug in your numbers, and we use it quite a bit.
Yes, I have it on my phone, and it's an app. I just
So we've talked quite a bit about a lot of important information about our health and about our heart, and really glad to be focusing today on your specialty, and this is what you do every day. Anything else you want to add that we haven't talked about?
Well, you know what, I got a text about the keto diet. I think it's all the rave now. Everybody's talking about the keto diet, and they want to know what the impact of the keto diet is on heart disease. I think it's too early.
Well, hold up. Let me interrupt. Briefly describe what that diet is.
Well, I don't know whether I know it all, but basically it's a diet that is very low in carb and high in fats and protein. That will put you in ketosis and cause a lot of weight loss, okay? Because you become more or less hypercatabolic, from my understanding. The question is, what happens on a diet like this? The one thing I can say is that, and this is really looking at the data from different diets, that diets that are plant-based, high protein, low carb diets are generally better in long-term outcome than diets that are low protein and high carb. But the key there is plant-based, and I think one of the concerns I have about the keto diet is there's a lot of push to eat a lot of animal protein. And we know, there used to be the Atkins diet before, and I hear Dr. Atkins died from a heart attack.
I heard the same thing, by the way.
Go figure. And that was kind of a precursor to the keto diet. I know there'll be a disagreement, but I think we'll know the answers 5 years from now when people have been on it long enough.
My review, as I recall, was that was not a good diet.
No.
I forget the exact reason why, but my understanding is plant-based is the way to go.
Definitely,
and we want those complex carbohydrates versus simple carbohydrates. And again, that gets into a more wholesome type diet. We're getting so much sugar in our diets, and those are things we really don't want.
I would argue that sugar is the largest drug in this world.
Right.
We get addicted to it. We can't get off it, and they put sugar in everything.
And I'll be honest, one of the things over the past months that have impressed me is how our government allows this to happen. I don't know if it's the lobbyists or what.
I think it's the lobbyists more than anything else. Let's not get into the politics of it. But
we don't want to do that. Yes, we don't want to do that. But it is interesting how we do have to be educated more so these days and do our research and make some good decisions, because these are life-changing decisions. So, anything else you want to say about cardiology?
No, I think prevention. You know, what do we say? An ounce of prevention is worth a pound of cure. A lot of what happens in cardiology can be prevented. So, stop smoking, exercise, live a healthy lifestyle, and listen to your physician, and be a little more objective about, you know, resisting medications, because that's one of the biggest problems, resisting even aspirins or resisting a statin.
And I'm glad you said that, because I meant to make this clear, and maybe you can share it. When someone has established heart disease and we put them on these medications, how long will they be taking these medications?
Yeah, it's a lifetime.
It's a lifetime.
It's a lifetime. And, you know, I'm sure there's a misconception out there, and I'm sure you've heard it before, that especially with hypertension, that, you know, once you get on blood pressure medications, you can't get off it. As if it's a medication that's the reason you can't get off it.
Right.
You know, but the truth of the matter is that these are chronic conditions, and for as long as you live, and if we want to prolong your life and have a better quality of life, you have to be on medications and do the lifestyle things, the so-called therapeutic lifestyle changes that would, you know, help these diseases from getting worse.
And we may not have the data in front of us, but it is clear that the medications have saved and prevented quite a bit of surgeries and things of that nature too.
Absolutely. They've prevented heart attacks. They've prevented patients getting chronic kidney disease, which is another big one, especially in the African American community. I mean, you know, they've prevented strokes. So without a doubt, these medications have done a lot. You know?
Rumor has it that over in the UK, statins are available over the counter. Have you heard that before? Yeah, I've been telling people that for years, and I haven't had a chance to now go back and verify it. But over there, they're more readily available.
Yeah.
I don't know if that country is just more progressive than we are from a cardiac standpoint and medical standpoint.
Yeah, I don't know. At least they have universal health care, but that's another topic.
That's political, right? So I know we're coming towards the end of the show. I'll tell you, man, it's been great having a chance to talk about a very important topic. Again, my name is Dr. Darryl Hill. I can be reached at 301-497-0401 or laurelmedicine.com. We are always open there 24 hours a day. And if you want to just share your information again.
Yes, again, my name is Ayim Jamson. I'm a cardiologist. My office number is 301-595-0356. And I can be reached at website is www.metrocardiovascular.com. And you can always send us emails at info@metrocardiovascular.com. Thank you.
And we look forward to having more interesting and relevant topics to help you stay healthy. And next week, we should have Dr. Charles Wang in the house, where we will be talking more about medical marijuana and all the excitement in that area. Outside of that, I think we can say goodbye and say thank you for tuning in, and we look forward to seeing you at our next episode.
Okay.